Please welcome IHI Vice President of Safety, Jeff Salvan Harmon.
Everyone. It's an honor to introduce our next and final main stage session of the Patient Safety Congress program, which highlights a critical element of patient safety, translating evidence into reliable practice. We've all heard that it takes 17 years, give or take, for research evidence to become standard practice in medicine. Have you ever wondered what it would take to accelerate that change? For the past 3 decades, Intermountain Health has been at the forefront of building a learning health system, deliberately aligning people, data, and processes to drive safer, more effective care. Their approach offers valuable lessons on how to spread and scale best practices, even in the face of system-wide changes like mergers and acquisitions. We're fortunate to hear today from Dr. Raj Shrivastava, a leader in this work. As Chief Clinical Programs Officer at Intermountain Health, Dr. Shrivastava oversees efforts to integrate evidence-based standards across a vast range of specialties. He also leads Intermountain Healthcare Delivery Institute, driving implementation science and applied research to ensure that clinical improvements translate into real-world impact. Please join me in a warm welcome for Dr. Raj Shrivastava.
Okay. Well, it's great to be here. Really appreciate the welcome, Jeff. I'm a longtime fan of IHI. Intermountain and IHI go way back. In fact, because of that relationship with the founder, Don Berwick, and the first Chief Quality Officer, Brent James, from IHI and Intermountain, I think I'm kind of here today because of that, how that influenced my career. So just wanted to share that I do have a disclosure. It's not actually ACCME defined and eligible. I just share it everywhere because it's easier to just share. So I'm going to do that. Look, I am really excited today and heard speakers yesterday and this morning and thought I would try to weave in what I heard with what I'm going to speak with you about today. So let's just start with this. We know healthcare is complex, and it continues to get more complex. When I finished fellowship, there were certain ways we were doing it. There were certain hours we worked. The data showed people stayed in the hospital a little bit longer, and so much has shifted. Reminds me of when we heard this from every speaker who spoke about what is really hard today. Now, I'm an optimistic person by nature, if you know me. I have trouble dwelling on challenges, but it's hard not to acknowledge them because they're very real. Health systems, we thought it was hard when all health systems are dealing with was, loss of trust and inflation and workforce challenges and then a lot has changed in healthcare. And so there's a lot of concern, how are we gonna stay true to our mission? Payers are facing all kinds of challenges, and with the murder of the United Health CEO, it caused a reaction that was shocking and out there. So people are really frustrated. Providers, burnout, you're asking me to do one more thing. This is really hard. When are you coming to help us? When can I remember the joy I felt why I went into this for the first time? And of course, at the end of the day, patients. How much of what are we designing fit what patients really need? what they are asking us for. So I think we're challenged. Okay, let's just set a few ground rules, despite what you may have read in the paper in the last 2 months. This is healthcare today. We are set up for rescue care. We're really good in the US for that. I'm Canadian, by the way, by birth. No, we're not yet the 51st state. Yeah, you're joking. Let's see what happens. I trained in Canada, and the Canadian healthcare system, the American healthcare system, actually has a lot of similarities in that rescue care is amazing. If I clutch my chest, I'm going to go somewhere close by, they're going to know generally what to do really well. It's pretty amazing. And yet, we know if we're going to make the impact on populations, we have to get to prevention care. Raj, why didn't you wake up an hour early and do your yoga? Because I didn't. Sorry. Okay. And we're paying different models. So historically, prior to 2 months ago, every administration was on this relentless pursuit to pay not for value-based care, not for fee-for-service care, but value-based care. I'm hoping that stays true because that will help change the way we behave. Today, every dollar Intermountain makes in revenue, 37 cents on the dollar is based on prevention care. Okay, so now are we operating differently? As I mentioned before, I was actually in fellowship when this book came out, and I was like, oh, somebody hands me this book in the fellowship. I look at it, I'm looking at the front, and I'm like, oh, these are people that I just met with, Dawn and Brent. And I'm like, this is incredible. And so when we talk about healthcare quality back, the Institute of Medicine, what it was called that, 6 things, different things. And for a long time, people were like, wait, what are these? How are we going to focus on them? What are we going to do? And in here is safety. Another big challenge we face, it just takes a long time from when we first know something to then when it gets out there, to then when we start to practice it, to then when it becomes routine care. And that sort of famous 17-year quote is actually quite real. This is my view of patient safety. So in 2008, I was called by the third person on the left. I'm that first person on the left, Chris Landrigan. We did fellowship together in Boston. And he called and said, hey, I think we figured something out that if we, at the end of a shift, have the interns in a teaching hospital share a structured format to hand off what just happened to what they can expect, we've decreased medical errors. And at the time, I was the chair of a hospital research network, and so said, great, let's study it. And so this is the first paper that we published back in 2014, got the grant in 2009, 2010, showed if you do this reliably, you get a reduction in errors. Okay, so if you think about it, there have been studies, 4 landmark studies that our academic team has done. 20,000 patient lives, 50 hospitals, about $9 million in federal funding. Everyone shows prevention of harm, 30 to 47%. Great. How many people are doing it reliably in their place every day? I can't put my hand up. Okay, so it even won the Eisenberg 2016 award. So there's Nancy Spector beside me, Chris Landrigan, Amy Starmer, Ted Sektish, Dan West, representing not 6 people's work, hundreds of people's work. In fact, when the award was won, we sent everybody a letter to them and their chair or their department head and said, congratulations, so-and-so has won this national patient safety award. Okay, but things haven't totally changed. Why is that? 50 hospital systems, are they all set up? I mean, we heard that yesterday, right? Every system perfectly designed to get the results it gets. So we must not be designed to do this reliably. Well, how are we implementing? So with that, I want to give an example just from the health system I've been working at since after fellowship. So Intermountain Health. I do look at us as a learning health system. I know other leaders have said that. And so I'm going to see if I can convince you of that, what I mean by a learning health system. So a few things. The first question I often get, oh, Intermountain, that's in Utah, right? And I say, yes, and. So if you've heard about Intermountain, often you may have heard about it from 2017 or before. So I'm just going to catch you up for the last few years. Intermountain is in 6 states in the Intermountain West, okay? Utah, Nevada, Idaho, Colorado, Montana, Wyoming. Here they are. 33 hospitals, just under 5,000 beds. We have a lot of clinics, and we have a lot of caregivers. We employ just over 5,000 physicians and advanced practice providers. We have another 5,000 that are affiliated. So we have a mixed group. We're not Kaiser, we're not closed. It's an open system. Just wanted to share that when people are like, well, of course you can do that in Utah because you're Intermountain. Everybody works with you. Everybody works with you. Not totally true, but that's our aspiration. But everybody doesn't work for us. That's not where the paychecks come from. So just to know, it's a mixed model. The other thing about Intermountain, we have our own insurance company, Select Health, over 1 million members. That's when you can do a lot of value-based play, is if you have that. Okay, so Intermountain had a merger, and so I'm showing you the numbers before in the merger. Here are some of the core beliefs that we have together. Let me just... Okay, so 2 things. 1, reducing variation leads to higher reliability, better outcomes. Anybody want to disagree? You don't have to. You can tell me outside. However, at the very top, we say this, and we want to live it. Okay, second, it's our physicians and advanced practice providers that are going to set our clinical priorities. It's not the boardroom. It's not the CEO. It's not the CFO. It's not the COO. It's not the chief clinical officer. It is at the level of decision-making of that specialty or primary care that says, this is the most important thing we need to focus on this year. All right. Here's another thing that we have worked through, and I think everybody here appreciates that. Different kinds of change require different solutions. So in that triangle is how we think about technology. If we just have to standardize an order set, 1 order set, not 33 order sets, there's 1, we'll just standard it. That's like standard technology, okay? Hit the button, do that. Every organization, all of your organizations, everybody practices evidence-based practices, okay? Everybody does it. That's that big blue circle. Often we talk about how do you have evidence-based practice with tech support, with your EMR, with a vendor, with other things. Okay, that's in that other circle. Now, here's what I'm going to talk about for the rest of the time because we've designed the system this way. Oops. When you know if the processes are done reliably, it's going to lead to a better outcome because the link has been super strong and supported by excellent evidence. By the way, we don't know that about a lot of things, but we know it about enough. Then we do this. It's called a clinical best practice integration project. And all we do is we do many things, but we measure the team's adherence to that process. Okay, so that's a subset of many, many things we and others do. So let's talk about, just to catch you up from 2017 on, just in case you were wondering what happened. So at Intermountain, Brent James, first Chief Quality Officer, joined in '92, created the Advanced Training Program, the first quality improvement program in healthcare of its kind. And he's trained, there have been, in the ATP class, it's still running. I get to oversee it now. It is such a joy to have, because you can train people to think, and you can catch them up to methods that matter, and we have learned now, and we can bring in to figure out how we do that. Secondly, Intermountain did something where they created clinical programs. That's the by specialty. By the way, how did they end up on the first 10? That accounts for 94% of a hospital's budget just back in the day. That's how they decided, okay? So let's just have the group musculoskeletal say, what are the best practices and how do we need to do this? All right. I'm going to walk through this model. In 2018, we underwent our fourth CEO. And our fourth CEO very challenged us to say, wait a minute, I practiced here, Mark Harrison, I practiced here, and then I went away to Cleveland, and I came back. How often are we doing this? And the answer was, well, we don't always measure it. That didn't go over so well. And frankly, I think he was right. Because if you create a system and you don't monitor it, you drift. And so you really need to hold yourself to what are we supposed to be measuring today. So we created a scientific method. I'm going to show it to you in a minute. That's our model. And then we underwent a merger. Anybody merge in the last 5 years? Can you raise your hand? Okay, not as many as I thought. But I'm going to say this, slightly disruptive. Not clear it proves everything it needs to prove in terms of like, oh, we're going to lower costs, we're going to spread it out, it totally works. Yeah, maybe, but I need to know it from the patient level, from the quality and safety, and all the pieces are supposed to do, especially reliable care. All right, so we merged. So we went from one state to a big footprint, 620,000 square miles, lots of rural health, lots of underinsured folks, and that's our current place. And then we underwent clinical integration. Let's bring certain parts of the organization together to see what we can do by changing that. Okay, so clinical programs. Here was the charge that I heard from my boss, the Chief Clinical Officer, J.P. Valland, when he offered me the role. He said this, Raj, we're known for this, but this is our footprint. Can we take what we've built and spread it? And can you do it with like 80% less resources or something like that? And I was like, oh, of course. If we have the data. I know we've heard this. Why do I have so much data on this device, and yet I don't have that in healthcare? So I thought we had the data, and we're working on it. So I'm going to show you some of those pieces. Secondly, because we had the Healthcare Delivery Institute and the Advanced Training Program, we got to alter it just a bit, stick to the core principles, teach how to use it, but why don't we train people together? Why don't we bring in, and so I said I was a pediatric hospitalist, I practice at Primary Children's. I'm also a quality improver. I also used to do my own statistics, and I think I'm an implementation scientist, but that's only because the NIH pays us $7 million for me to say so. But I don't think I think I'm somebody who's collecting all the different pieces to work together. We're just learning together, and when you put people in a room with these mad skills, incredible things happen for patients. However, we put in implementation science in the new curriculum. We don't call it that. We don't talk about grant funding. We talk about how patients are getting more reliable care, and we work through that. By the way, what do you want to do after a merger? You want to integrate. Well, then we have the class is open. People can still take it from external. We have a lot of people who do. We have people internally who take it. But every spring since the merger, we closed it to external people. And we just said, hey, who needs it now at the senior leadership level. So they've deliberately put in different cohorts each spring. Talk about an emerger. Well, they're doing this and we're doing this. No. We are co-creating something together. Let's bring them through. And this class will help sort of set the stage of where did we come from and where are we going to need to go together. All right, so here's the model. And I'm just going to, there are a few things that you'll notice here as we go through. So I'm going to walk through step by step. You can see that on here, but I'm going to give you an example. We had 3 objectives when we created the model in 2018. 1, recognizing there were so many good things happening at Intermountain, but we needed to say, how are we going to do it in the future? We called a bunch of friends. Turns out there are a lot of friends. We called people at IHI. We said, how's your model here? Called people at different health systems. Called people internationally. The NHS has a model. Australia, there are friends who have there. Other places, people freely shared. Great. So then we created this model. Here were the goals. 1, we're not going to wait 17 years. If that clinical group says it's ready for every day, we're going to roll it out so it is ready every day. 2, we're going to scale it. Turns out you can actually probably scale almost anything if you have enough resource. But people want to scale. Okay, but the reason I think people want to scale is because of this 3rd thing. We want to sustain. That doesn't mean just because it's a board goal, we sustain and then we declare victory and move on. We've done that. It is years later. Years later. So I'm going to show you one example through COVID that sustained. Well, you can tell me if it sustained to the adherence. All right. For these clinical program leaders, there's a physician leader and largely a nurse leader. Here's what their job is, and this is their area of expertise you can see up here. You're going to meet people in the new area. It's going to be their first introduction. They may have heard something. By the way, we may have gotten their pay wrong. We may have switched their Outlook or their email. We may have changed their devices. We may have done all kinds of things, and then we're going to come in and say, hey, let's spread this best practice. So they have to build relationships. They have to develop trust. And then they have to say, what can we do together? And so that is what we're relearning in a whole new area we have never been at. So I'm going to give you the example now, walking through it. So here we have the stroke example through here. Patients come in, they get admitted to the emergency department. There's a suspect of they have a stroke. The best evidence says if they have a certain type of stroke, they should get a clot-busting drug. They should get it under an hour. It's been lowered to 45 minutes, but when this came out, it was under an hour. So Dan talked about this yesterday. Get a leverage point. Don't do 53 things, do 3. They said, oh, give that clot-busting drug in under an hour. That's all we want to do. And get a neurologist on the phone in 10 minutes or on the video. We have rural hospitals, 4-bed ER, 10 other beds. They see 2 of these a year. Get a neurologist in 10 minutes. And then let's get a CT in 15 minutes. Okay, we have a lot of data, but you have to build a measurement system that captures what you need. And then this is what I find a lot of fun implementing. What are the strategies? Now, this is where the local place gets to say, no, this is what's going to work for us. These are our resources. We are empowered. We agree to give the alteplase under an hour. Let us figure out how. So people figured out how. Okay, then we piloted. What you're going to see here is the door-to-needle time, the treatment. The standard at the time was under an hour. For the whole system in 2016 and 2017 hadn't met the standard. when we piloted 3 EDs, it finally hit the standard. And then I'm just going to show you a video just so you can see a story of one of the patients that this was piloted on.
The mission of Intermountain Healthcare is to help people live the healthiest lives possible. What that means for patients that have strokes is helping them to get treatment as soon as possible so that they can return to living their normal life with a minimal amount of disability due to their stroke. To achieve this, we spent years developing a care process model for stroke care. When we really turned the corner with respect to stroke care was when we started to use quality improvement to take that care process model that was based on best evidence in the literature and develop a way to implement that within our emergency departments and within our ICUs. The main goal that quality improvement achieves is it aligns all of the caregivers around the care process model, in our case, around stroke, towards a common set of goals, and then allows them to work together to develop techniques to achieve those goals. ATP is part of that refocus that allows frontline caregivers to implement care process models and provide evidence-based practice.
So she was out at recess and her head started to hurt. She went into the bathroom, and while she was using the bathroom, she fell off the toilet. And luckily for us, there was 2 ladies had entered the bathroom and seen Addie on the ground. They had asked Addie if she could unlock the stall, and Addie couldn't move.
So this didn't feel like a seizure. At that time, I asked the physician if we should activate our stroke protocol, and Dr. Call happened to be the on-call neurologist in our department at that time. He came in and he did another neurological exam on this patient, confirming that her symptoms did feel like a stroke. We moved forward with our stroke protocol, which involves a team of caregivers, and this activated our radiology department to clear a scanner. We immediately rushed over to CAT scan, did an image of her brain which showed abnormal findings.
There were so many doctors, and they put her in a CT scan, and they identified that she indeed was having a stroke. When they presented the reversal drug to us, that was really hard. Luckily, the neuro team was pretty good at trying to answer questions that I had. It made me feel comfortable enough to let them give her the drug that would help, and it did, within like 20 minutes.
So what the CPM does here at Intermountain is provide all providers in the system a framework with which to address this disease. This care process model, the acute management or emergent management of acute ischemic stroke, allows emergency physicians, neurologists, nurses, everyone throughout the system who is going to deal with a stroke patient in that first few hours to know what's most important, what are the key things that we need to know and remember to do. To me, it's impressive how the CPM informed her care, mostly because everyone in the emergency department was aware of the CPM, aware of what's important, aware of what's not important, and aware of their jobs, their roles, and their part of the process. So once we identified that it was a stroke, things went smoothly. It was 8-year-old, 80-year-old, it doesn't matter. We got those most important things done so that we could get the information to the right place and make the decisions that we needed to make that allow us to treat the patients in a fast and efficient manner and make sure we get the right treatments to the right patients in the best amount of time.
Had they not been on top of it with their A game, I mean, I don't think she'd be doing as good as she is. Because her progress has been incredibly quick. So, but we just want to say thank you.
Together, we were achieving success to reduce the time to treatment for patients, which corresponds to saving brain and improving their level of disability on discharge.
Okay. Yesterday we heard Dan say start with a burst. That was our burst. The protocol was not designed for kids. It didn't happen at the Children's Hospital attached to the university that I practice at. It happened in a community hospital where they see a lot of kids, but somebody said, this feels like a stroke. And we know this is applying. Turns out it was the exact right treatment to do. But that translation, that making the daily work easier to allow somebody to think out of the box. That nurse, by the way, Cassie, she's in our current ATP cohort. She's a nurse manager. It's incredible. I've watched that video a lot. But to have her in the class has been such a joy. All right. By the way, in 2016, 2017, what had the system done to solve this problem of timely door-to-needle? $50 million in telehealth. We're really well known for telehealth. It's actually kind of cool because we have to invest in it because our patients are from such this big geography, so people come from all over to learn. Well, we had already built that. Oh, well, let's hire a bunch of neurologists. Done that too. But until we use this method to pilot, finally, 57 minutes. Okay, so that was 3 EDs. Then in 2019, the team said, okay, Raj, we're gonna scale it. And I was like, oh, there's no way. You can't scale this to all the other hospitals. They were like, watch us. So they did. They scaled it to all the other hospitals. That was my naivete, thinking like a researcher, thinking like, oh, well, you can't do it this way or this. And watching the team go was phenomenal. Okay, how did they do that year? 52 minutes. All right, well, let's talk about sustain for a minute. Are we designing our systems, making care better and easier, safer, reliably? Well, in 2020, they hit 48 minutes. But something else happened in 2020. Sure, the ERs were very quiet for about 3 months because everybody was afraid to go to the ER. But then people were coming. And if you know this literature, are there any neurologists, by the way? I should be really careful because people will know a lot more than I do. There's more strokes happening because the COVID virus, as it causes a disease, there's so much more, and we're seeing more strokes. Did they miss a beat in 2020? How about 2021, Omicron? Did they miss a beat? How about 2022? Okay, by the way, this literature, you publish it, you gotta be at an academic hospital of like 300-400 beds minimum to get this type of response all the time. This is small hospitals and big hospitals working in concert. So they've sustained, I asked them to pull the data just last year for this, so you could see, okay, door-to-needle time, 37 minutes. Phenomenal work by the teams. Oh. What about new evidence? Because new evidence comes up. How are we gonna adjust? So what you'll see here is the door-to-needle time from 2015 to 2024. And you can see here they dropped below. Remember, things have shifted. So now they're saying, oh, try to treat more patients under 45 minutes. That's why they're driving it lower and lower, because the rules are changing. We live in a world where the rules are changing because they're always supposed to get better. So let's adopt that. But what about the new evidence? So here's the thing. If you create the system, you can add the new evidence because you've created the system. So when they say, well, hey, there's a certain type of stroke, and we know for this drug, by the way, so certain type of stroke, we can actually do a certain radiology can go in, interventional radiology, go into that large bore IV and sort of pull out the clot all the way through. Everybody can tell I'm a hospitalist now. Okay, and yet, you can do it if the stroke is under 6 hours, but Raj, we now know you can do it 6 to 24 hours, so we can expand those services. So let's do so, because you've built the system. As the new evidence has come, it just rolls right in. Secondly, new knowledge or new drug, new technology, new drug, tenecteplase. We think it's better, sort of. It is cheaper, and you can just give a shot instead of hanging the IV. So a lot of health systems have switched. We're going to have to study it because we want to know in the real world it is better. I think a lot of people are not totally convinced, but people have made the switch. Okay, is it safe? Let's learn together. We just have the data we're collecting. And we learned before you had to be last known well of your symptoms within 4 hours to get the benefit of the drug. But then the famous study came out, the wake-up study and the extend study. No, it can actually be more than 4.5 hours. So now you can get a group of patients that you were never delivering that better care for. You can just give it to them. So you can roll this in. Hey, what's this? We merged. I can't show you data from the other 8 hospitals today. I may have been trying for the last year and a half. We're undergoing a merger of our EMR, where we're actually switching. We have 2 EMRs. The old system had Epic. The new one has iCentra, and we're switching to Epic. Every single place, all on one day. Don't reach out on September 5th. They call it the biggest Epic implementation ever. Okay. No stress whatsoever. However, I want to see the data that then says, how are we doing as a system so we can learn from each other. All right. Well, let's just talk about, we talk a lot about bell-shaped curves and moving the needle. This, I just thought I would show you. This is every single patient's door-to-needle time that had a stroke in 2017. And this was the bar. So you can see that there was a wider distribution in 2017 because we only piloted. But then in 2024, where are we? Those 356 patients, that's what each of the blue lines are. We've moved the curve, shifted. That's our responsibility. Every one of these is a patient who gets a disability, often permanent, if we don't do it in time. And of course, it's our responsibility to share. It's not just you have to be at Intermountain. You can do this. We just have to share how. How did we do this? You look at it yourself, figure out if it applies to you, call us, what do you want to see? So we, of course, we've published this as well. And it's actually our implementation science folks who helped us get it into the right journal with the right terms, language, and it's bringing together fields, the clinical disciplines, the implementation disciplines, the quality improvers, the statisticians, others, all coming together. All right, I've talked to you about the stroke example, and I'm actually presenting to our board tomorrow, so thank you for being a practice audience as I go to the board. I get to say last year we did that 590 times. That's all the patients who got that, 20 minutes faster. Okay, there are other amazing things. How are we ventilating our patients? How are we looking after women who are pregnant and they have a tracing, and 80% of the tracings, it's not clear what to do. 10% it's like crash C-section, 10% it's like ignore it. 80%, it's 2 a.m. We have a bundle where the nurse will now call the doc and say, hey, I know we're rolling this out. I know it's 2 a.m. I know you're at home. What are we going to do? And so on. All right. I just want to leave you with this. Dan talked about restacking resources. Okay. This probably is not going to be something I'll say tomorrow at the board meeting. I think the board is a governance model, right? We all have that. At Intermountain, we have reorganized the clinical oversight of the clinical programs such that the chief clinical officer and the chief nursing executive and this team, I'm right there, but there are many others, including our chief quality and safety officer, who's new, Cara Camiolo, just took the role. You'll, I'm sure, meet her over time. This group sets what are the things we're prioritizing. This is the steering committee, the CNOs and CMOs of all the regions to say, how will we implement this? And then this is the clinical programs. And remember, they're the ones saying, this is our number 1 thing, or this is our number 2 thing. How many do they want? They probably want 10. they get 2. Last year they got 1. Next year they'll get 3. All right. This system, you can say it exists to prioritize. I'm going to say it exists to prioritize and it exists to learn. What are the systematic barriers and facilitators that we're coming across? What are the one-off barriers and facilitators we're coming across? Everybody screams about data or this or that. I don't know that to be true. But we're going to learn and share that learning back with our oversight committee so they can say, wait a minute, we really do have a problem here. It wasn't just the noise. There's actually some signal in here as well. This is actually I thought I would just share, so what got approved this year? This is our 2025 approved work by clinical program. Mix of hospital stuff, more hospital stuff, because that's how most of the stuff gets started, but we brought back the primary preventive clinical program. So they are working on prevention things. Remember, we're value-based as well. We're paid for that. So what can we do to move that needle as well? This is just one example also I wanted to bring through from a prevention side. We've known for a long time routine prescribing of antibiotics for certain conditions may not be necessary at all. And if they are given, you can reduce the duration of antibiotics. And you can select an antibiotic that is preferred, more narrow spectrum. So we, along with 18 other health systems, people are probably here from them, got funding from PCORI, Patient-Centered Outcomes Research Institute, that has $50 million that are paying health systems to implement care better. I have never seen that in my career. And all we did in the grant was basically wrap up this top with a bow and turn it in. Because said, hey, this is actually how we're organized, operating, and doing this. We're so fortunate to receive it, and we're fortunate enough to get this particular grant. They gave us a first grant to set up our infrastructure. And now they're giving us a grant to set up this. Well, of the 19 health systems, we have to learn together. How are you doing it? How are you doing it? How are you doing it? What are our common barriers and facilitators? What are our bright spots? And is it a bright spot that could actually go across? Because all we're doing is trying to get better antibiotics for kids. I mean, they kind of are our future, speaking as a pediatric hospitalist. Secondly, I'm pretty sure all of you were a kid once. We're 20%, we're only 5% of the number of systems, but we're 20% of the denominator because we have 270,000 kids. There are a lot of kids who live in the Intermountain West, in case you were wondering. We're doing it in 250 sites. What are these sites? Every place that's family practice, every place that's pediatrics, every general emergency department, every urgent care, and telehealth. I'm mildly stressed about this implementation, except I'm not implementing. The team is working together. We have a system. It will be the biggest implementation I've ever had the pleasure of being a part of. But how cool will it be that us and 18 other systems are doing it in concert? There's no competition, by the way. Let's just have that awesome run chart of how often are we doing it together and then learn from each other. All right, so I just wanted to share how we rearranged ourselves a little bit to stay true to our legacy, but kind of embrace this future of, hey, if you ever say, hey, we always would hear about what happened in Utah. Now we're being asked to do it bigger. We have a method. The method shortens the timeline to routine care. It scales, and so far, it's sustaining. Of the 6 projects I showed you that list, 5 have sustained, 1 has not. Oh, well, Raj, what happened? Well, guess what? Somebody went and got a grant to study what happened. Because we have to learn, why was there drift in year 5? And by the way, a lot of these sustained all throughout the pandemic as well. talk about the biggest stressor. I would have thought that would have derailed everything. So, and we're connecting. This is just a org slide of how we connect the clinical programs with our service lines in all the regions. So we have to work in together, and then we kind of hold true to the mission. Can we capture what we're measuring? And I'm going to say this. I have yet to meet a patient who would say to me, you know what, I didn't want that door to needle time 21 minutes faster. So with that, just wanted to, ATP is still alive and well, and this is not just an endorsement. I heard yesterday from Patricia, there's so much training out there, IHI. I actually took the IHI open school back in the day when it was new, and I was like, oh my gosh, what's quality improvement? And I've appreciated people who have trained over years, decades, because what I've seen is the evolution in the training. Wait, what's happening in 2025 is kind of different than what happened in 1995. So we do have to evolve. And so my only advice is if you're serious, get trained. And I heard a lot about the training that Patricia and the group were offering as well, which I think is amazing. Okay, with that, I just want to thank you for your time. Oh, and